Endocrine and metabolic disorders affect approximately 1 in 1,000 to 2,000 newborns. Newborn screening programs identify about 1 in 2,000 to 4,000 cases, making interpretation of these results a critical skill. The pathophysiology centers on gene mutations that create 3 major problems. Enzymes may be completely absent or defective, hormones can be overproduced or underproduced, and normal physiological regulation becomes disrupted. Think of it as a factory line where either the workers don't show up, they're making mistakes, or the supervisor can't control production levels. Early diagnosis prevents permanent damage. The brain needs thyroid hormone for development. The adrenals need cortisol for stress response. Without prompt intervention, permanent neurological and developmental consequences occur. Timing of presentation follows a predictable pattern. During pregnancy, the maternal placental unit provides significant metabolic support. The mother's hormones cross the placenta. Her metabolism compensates for fetal deficiencies. Once that umbilical cord is cut, the newborn must suddenly manage independently. This explains why many endocrine disorders manifest in the first days to weeks of life, not immediately at birth. This protective effect determines when symptoms appear and why initial newborn screens might miss certain conditions. Recognition of this transition period becomes crucial when evaluating cases where symptom onset occurs days or weeks after an initially normal appearance. Certain clinical findings should immediately raise your suspicion for endocrine and metabolic disorders. Persistent or recurrent hypoglycemia tops this list. While transient hypoglycemia occurs in many newborns, episodes that persist despite adequate feeding or recur after initial correction suggest an underlying metabolic problem. Unexplained metabolic acidosis represents another major red flag. When standard causes like sepsis or hypoxia have been ruled out, consider inborn errors of metabolism. Similarly, severe electrolyte abnormalities, sodium below 130 or potassium above 6, often signal adrenal insufficiency or congenital adrenal hyperplasia. Watch for infants who don't respond appropriately to standard treatments. The septic-appearing baby who doesn't improve with antibiotics and fluids might have an organic acidemia. The hypoglycemic infant requiring unusually high glucose infusion rates likely has hyperinsulinism or a fatty acid oxidation defect. Family history provides crucial clues. Unexplained infant deaths, particularly in male siblings, suggest X-linked disorders. Consanguinity increases risk for autosomal recessive conditions. These patterns often emerge only through careful questioning. Your first-line laboratory evaluation includes glucose, arterial blood gas, electrolytes, ammonia, and lactate. These basic tests can quickly identify or exclude many metabolic emergencies. Hypoglycemia with elevated lactate suggests gluconeogenesis defects. Hyperammonemia points toward urea cycle disorders. Metabolic acidosis with elevated anion gap narrows your differentials significantly. Remember that newborn screening results typically return between days 5 and 14 of life. Many metabolic crises occur before these results arrive. Clinical recognition remains your primary diagnostic tool during this vulnerable period. Endocrine and metabolic disorders mimic common neonatal problems. The baby treated for sepsis might have organic acidemia. Apparent feeding intolerance could be galactosemia. This overlap creates diagnostic challenges in early life. Hypoglycemia is the most frequent sign, persisting despite adequate glucose or recurring after correction. Standard infusion rates fail. These infants need 12 to 15 milligrams per kilogram per minute or more. Clinical features include poor feeding, vomiting, and progressive lethargy. Parents report babies feeding less vigorously, sleeping more, harder to arouse. These changes can rapidly progress to seizures within hours. Examination reveals jaundice beyond physiologic levels, particularly conjugated hyperbilirubinemia. Hepatomegaly develops from toxic metabolite accumulation. Respiratory distress without lung disease and unexplained hypotonia support the diagnosis. Distinctive odors narrow the differential. Musty phenylketonuria, sweet maple syrup smell of branched chain disorders. Train yourself to notice these during examination. Multiple organs become involved as metabolic derangements affect cellular function body-wide. The brain shows encephalopathy, liver dysfunction develops, muscles weaken, and cardiomyopathy may occur. This multi-system involvement distinguishes metabolic disorders from isolated organ pathology. During fetal life, glucose regulation is simple. The baby relies entirely on maternal supply through the placenta. Blood glucose levels mirror the mother's, with no need for independent regulation. This changes dramatically at birth. The moment the umbilical cord is clamped, a hormonal cascade begins. Catecholamines surge, glucagon rises, and insulin levels drop. This coordinated response triggers two essential processes. Glycogen stores in the liver start breaking down, and gluconeogenesis begins converting amino acids and glycerol into glucose. Within hours, the newborn establishes independent glucose production. Normal glucose levels in newborns range from 40 to 80 milligrams per deciliter, lower than adult values but appropriate for neonatal metabolism. We define hypoglycemia as plasma glucose below 40 milligrams per deciliter, though this threshold has been debated for decades. Some experts argue for higher cutoffs, but 40 milligrams per deciliter remains the most widely accepted definition for intervention. Certain populations normally run lower glucose levels without pathology. Breastfed infants often have glucose values in the 30s during the first 24 hours while establishing feeding. Small for gestational age babies have limited glycogen stores, but adapt with alternative fuels like ketones. Premature infants lack both glycogen stores and mature gluconeogenic enzymes, making them particularly vulnerable. Recognizing these variations prevents unnecessary intervention while maintaining vigilance for true pathology. Neonatal hypoglycemia falls into two distinct categories that require different approaches. Transient hypoglycemia represents an adaptation challenge rather than true pathology. These infants respond quickly to brief interventions. A few boluses, temporary IV glucose, early frequent feeds. Once stabilized, they maintain normal glucose levels without ongoing support. Common causes include the stress of delivery, maternal medications like beta blockers or oral hypoglycemics, and temporary suppression of counter-regulatory hormones. The key feature is resolution. Within 48 to 72 hours, these babies regulate glucose normally. Persistent or recurrent hypoglycemia signals a fundamentally different problem. These infants require glucose infusion rates exceeding 8 to 10 milligrams per kilogram per minute, well above normal hepatic glucose production of 4 to 6 milligrams per kilogram per minute. Despite high glucose delivery, they continue having hypoglycemic episodes. Some need rates of 15 to 20 milligrams per kilogram per minute or higher. This pattern suggests intrinsic metabolic defects, hyperinsulinism, where insulin secretion continues despite low glucose, enzyme deficiencies blocking gluconeogenesis or glycogenolysis, counter-regulatory hormone deficiencies, or fatty acid oxidation defects preventing alternative fuel utilization. These conditions require prolonged management, often with specialized medications beyond glucose supplementation. The distinction between transient and persistent hypoglycemia drives your diagnostic evaluation and long-term management planning. The critical sample transforms hypoglycemia evaluation from guesswork to precise diagnosis. Timing is everything. Blood must be drawn during actual hypoglycemia, when glucose falls below 40 milligrams per deciliter. Once you've corrected the glucose, the diagnostic window closes. Insulin levels provide the most valuable information. Any detectable insulin above 2 micronits per milliliter during hypoglycemia is inappropriate. Insulin should be completely suppressed when glucose is low. Elevated insulin confirms hyperinsulinism, whether from beta cell hyperplasia, focal adenomatosis, or genetic channelopathies. Beta-hydroxybutyrate and free fatty acids offer supporting evidence. In hyperinsulinism, both remain suppressed. Beta-hydroxybutyrate below 1.8 millimoles per liter and free fatty acids below 1.7 millimoles per liter. Why? Insulin blocks lipolysis and ketogenesis. Normal infants generate ketones and mobilize fatty acids during hypoglycemia as alternative fuels. Their absence confirms insulin excess. Growth hormone and cortisol complete the hormonal assessment. Both should surge during hypoglycemia as part of the counter-regulatory response. Low levels suggest hypopituitarism or isolated hormone deficiencies. The glucagon stimulation test provides functional confirmation. Administer 0.03 milligrams per kilogram of glucagon during hypoglycemia. A glucose rise of 30 milligrams per deciliter or more indicates substantial glycogen stores still present despite hypoglycemia. classic for hyperinsulinism. This excessive glycogen storage occurs because insulin promotes glycogen synthesis even as glucose falls dangerously low. Initial stabilization follows a systematic approach. Start with an IV bolus of 2 milliliters per kilogram of D10W, delivering 200 milligrams per kilogram of glucose. This rapidly corrects hypoglycemia without causing rebound hyperglycemia. Follow immediately with continuous infusion at 6 to 8 milligrams per kilogram per minute. Calculate this rate precisely. It determines whether you're meeting or exceeding the infant's glucose requirements. For persistent hypoglycemia, management intensifies. Glucose infusion rates climb above 10, then 12, sometimes reaching 20 milligrams per kilogram per minute or higher. Peripheral IVs cannot handle dextrose concentrations above 12.5% due to osmolarity. You'll need central access, umbilical venous catheter or PICC line to deliver D15W, D20W, or even higher concentrations safely. The glucose infusion rate calculation becomes your guide. Multiply dextrose concentration by IV rate, divide by weight, and by 6. This number tells you exactly how much glucose you're providing per kilogram per minute. Track this carefully as you titrate therapy. When glucose requirements exceed 12 to 15 milligrams per kilogram per minute, despite appropriate management, consider diazoxide for suspected hyperinsulinism. This medication opens ATP-sensitive potassium channels, hyperpolarizing beta cells and blocking insulin secretion. Start at 5 to 10 milligrams per kilogram per day, divided every 8 hours. Weaning requires patience. Reduce glucose delivery by 1 to 2 milligrams per kilogram per minute every few hours, while monitoring closely. Rapid weaning triggers rebound hypoglycemia. Throughout this process, endocrinology consultation guides specialized testing and long-term management planning. The pathophysiology of hypoglycemia in infants of diabetic mothers follows a predictable sequence. Maternal hyperglycemia means glucose freely crosses the placenta, creating fetal hyperglycemia. The fetal pancreas responds by producing more insulin-secreting cells. The islets undergo actual hypertrophy, not just hyperplasia. By the third trimester, these infants secrete 2 to 3 times normal insulin levels. This chronic hyperinsulinemia drives metabolic changes. Excess glucose converts to glycogen in the liver and fat in adipose tissue. These babies develop the characteristic Cushingoid appearance. Round faces, thick subcutaneous fat, enlarged organs. They're metabolically programmed for a high glucose environment. At delivery, maternal glucose supply stops abruptly, but the baby's pancreas continues pumping out insulin. This mismatch causes rapid glucose consumption without adequate production. Hypoglycemia occurs in 5 to 50% of IDMs. The wide range reflects varying degrees of maternal glucose control. Poorly controlled diabetes produces more severe fetal hyperinsulinism. Timing follows a consistent pattern. Most hypoglycemic episodes occur within the first 2 to 4 hours after birth, when insulin levels remain elevated but glucose stores deplete rapidly. Unlike transient hypoglycemia in other newborns, IDM hypoglycemia often persists for 48 to 72 hours, sometimes longer. The hypertrophied pancreatic islets need time to downregulate insulin production and recognize the new, lower glucose environment. Infants of diabetic mothers face multiple complications beyond hypoglycemia, though hypoglycemia remains your primary concern. Macrosomia affects 15 to 45% of IDMs, with birth weights exceeding the 90th percentile. This increased size leads to birth trauma, shoulder dystocia, brachial plexus injuries, clavicular fractures. The combination of macrosomia and metabolic instability makes delivery planning crucial. Cardiac complications deserve special attention. Up to 40% of IDMs develop cardiomyopathy, typically presenting as septal hypertrophy. The interventricular septum thickens under insulin's growth-promoting effects, sometimes causing outflow obstruction. Most cases resolve within 6 months, but severe hypertrophy can compromise cardiac output in the immediate newborn period. Respiratory distress occurs more frequently than expected for gestational age. Despite being term or near term, these infants have delayed lung maturation. Maternal hyperglycemia interferes with cortisol's effect on surfactant production. They develop RDS patterns typically seen in premature infants. Electrolyte disturbances compound the metabolic chaos. Hypocalcemia affects 20 to 25% of IDMs, usually presenting between 24 and 72 hours. Hypomagnesemia often accompanies it, as maternal diabetes depletes magnesium stores. Both can trigger seizures if unrecognized. Polycythemia results from chronic intrauterine hypoxia. The hyperglycemic environment increases metabolic oxygen consumption. Hyperbilirubinemia follows, partly from polycythemia and partly from immature hepatic function. Renal vein thrombosis, though rare, occurs more frequently in IDMs due to polycythemia and dehydration. Small left colon syndrome presents as feeding intolerance and delayed meconium passage. Management begins before the first glucose check. When possible, initiate feeding within 30 minutes of birth. Breast milk or formula provides steady glucose input, while stimulating appropriate metabolic responses. Early feeding alone prevents hypoglycemia in many well-appearing IDMs. Glucose monitoring follows a strict schedule: 30 minutes, 1 hour, 2 hours, 4 hours, and 8 hours after birth. This frequent monitoring catches hypoglycemia during the highest risk period. Continue checks before feeds until values stabilize above 50 milligrams per deciliter for 24 hours. For mild hypoglycemia, glucose between 25 and 40 milligrams per deciliter in an asymptomatic infant, oral glucose gel offers first-line treatment. Apply 200 milligrams per kilogram of 40% dextrose gel to the buccal mucosa. This provides rapid absorption while avoiding IV placement. Recheck glucose in 30 minutes and refeed. Severe or persistent hypoglycemia requires intravenous therapy. Start with the standard bolus of 200 milligrams per kilogram, then continuous infusion. IDMs often need higher glucose infusion rates than other hypoglycemic newborns. 8 to 12 milligrams per kilogram per minute is common. Beyond glucose, systematic monitoring prevents other complications. Check calcium and magnesium at 24 hours, earlier if symptoms develop. Monitor hematocrit for polycythemia requiring partial exchange transfusion. Assess cardiac function if murmurs or respiratory distress develop. Watch for feeding intolerance, suggesting small left colon syndrome. This comprehensive approach addresses the full spectrum of IDM complications while maintaining focus on the critical glucose management. Congenital adrenal hyperplasia represents a family of autosomal recessive disorders that disrupt cortisol synthesis in the adrenal glands. When enzymes in the steroidogenesis pathway malfunction, the entire hormonal cascade shifts, creating both deficiencies and excesses that manifest clinically. 21-hydroxylase deficiency accounts for more than 95% of all CAH cases. This single enzyme defect explains why CAH presentations follow such consistent patterns. We're essentially seeing variations of the same metabolic disruption. The remaining 5% involves other enzyme deficiencies like 11-beta-hydroxylase or 17-alpha-hydroxylase, each creating distinct clinical pictures. With a worldwide incidence of 1 in 16,000 births, CAH ranks as the most common disorder of sex development. This frequency led to its inclusion in newborn screening panels across most developed countries. The screening measures 17-hydroxyprogesterone levels, catching most cases before life-threatening salt-wasting crises develop. The autosomal recessive inheritance pattern means both parents carry one mutated gene. Each pregnancy has a 25% chance of producing an affected child. Carrier frequency varies by population, about 1 in 60 in the general population, but higher in certain ethnic groups like Ashkenazi Jews or specific isolated populations. The pathophysiology starts with a blocked enzyme. 21-hydroxylase normally converts 17-hydroxyprogesterone to 11-deoxycortisol, a crucial step in cortisol production. Without this enzyme, cortisol synthesis stops. The pituitary gland senses low cortisol and responds by secreting more ACTH, trying to stimulate production. This ACTH surge drives the adrenal glands to work harder, causing them to enlarge, hence the term hyperplasia. But no amount of stimulation can overcome the enzyme block. Instead, cortisol precursors accumulate, particularly 17-hydroxyprogesterone. These precursors can't proceed down the cortisol pathway, so they divert into the only available route, androgen synthesis. The severity depends on residual enzyme activity. Simple virilizing CAH retains some 21-hydroxylase function, enough to prevent complete mineralocorticoid deficiency, but insufficient for normal cortisol production. These patients primarily show androgen excess effects. Salt-wasting CAH, affecting 75% of cases, involves complete or near-complete enzyme deficiency. Both glucocorticoid and mineralocorticoid pathways fail. Without aldosterone, the kidneys can't retain sodium or excrete potassium properly. This creates the characteristic electrolyte crisis that defines the salt-wasting phenotype. The combination of cortisol deficiency, aldosterone deficiency, and androgen excess produces the full clinical spectrum we recognize as classic CAH. Salt-wasting crisis typically emerges between 1 and 2 weeks of life, after newborn screening but before results return. The presentation can be catastrophic. Sodium levels drop to 121 to 129 milliequivalents per liter as the kidneys dump salt uncontrollably. Simultaneously, potassium rises to 5.8 to 8 milliequivalents per liter, reaching cardiotoxic levels. Hypoglycemia compounds the crisis. Without cortisol's counter-regulatory effects, glucose levels fall to 40 to 45 milligrams per deciliter. The combination of volume depletion, electrolyte chaos, and hypoglycemia creates profound shock. These infants arrive critically ill, lethargic, dehydrated, with poor perfusion and metabolic acidosis. Female infants with CAH present obvious physical findings at birth. Prenatal androgen exposure virilizes external genitalia, while internal structures develop normally. You'll see clitoromegaly ranging from mild enlargement to complete masculinization. The labia may be partially or completely fused, creating a scrotal appearance. Hyperpigmentation affects the genitalia and sometimes the nipples. ACTH cross-reacts with melanocyte receptors. The degree of virilization correlates with prenatal androgen exposure timing and severity. Early, severe exposure creates more dramatic changes. Despite external appearance, these infants have normal ovaries, fallopian tubes, and uterus. The internal structures developed before significant androgen exposure. Male infants present a diagnostic challenge. Their external genitalia appear normal since prenatal androgens simply enhanced normal male development. They might have subtle penile enlargement or scrotal hyperpigmentation, but these findings often go unnoticed. Without newborn screening, male infants typically present in salt-wasting crisis without warning signs. Laboratory diagnosis centers on elevated 17-hydroxyprogesterone, the substrate that accumulates behind the enzyme block. Levels exceed 10,000 nanograms per deciliter in classic CAH. Normal newborn values are below 100. This dramatic elevation makes the diagnosis straightforward when properly measured. Electrolyte patterns tell the story of mineralocorticoid deficiency. Sodium drops below 130 milliequivalents per liter as the kidneys cannot retain it. Potassium rises above 6 milliequivalents per liter, sometimes reaching 8 or 9, levels that risk cardiac arrhythmias. This combination of low sodium with high potassium in a newborn immediately suggests CAH, until proven otherwise. The androgen profile confirms the shunting towards sex hormone production. DHEA, androstenedione, and testosterone all elevate significantly. In affected females, testosterone levels match or exceed typical male ranges. These elevated androgens drive the prenatal virilization and continue affecting growth and development if untreated. Karyotype analysis in virilized females typically reveals 46XX chromosomes, confirming genetic female sex despite masculinized external appearance. This finding helps guide surgical planning and long-term management decisions. Additional testing shows the full extent of adrenal dysfunction. Aldosterone levels are low or undetectable in salt-wasting forms. Plasma renin activity elevates dramatically as the body tries to compensate for volume depletion. Cortisol remains inappropriately low despite stress, a finding that would trigger aggressive ACTH secretion in normal infants. Acute salt wasting crisis demands immediate intervention. Start with normal saline boluses to restore intravascular volume. These infants are profoundly dehydrated. Once IV access is secure, begin hydrocortisone at stress doses of 100 milligrams per meter squared per day, divided every 6 hours. This provides both glucocorticoid and mineralocorticoid activity in the acute phase. Electrolyte correction requires careful monitoring. Sodium rises slowly with saline administration and cortisol replacement. Hyperkalemia often needs specific treatment: calcium gluconate for cardiac protection, insulin with glucose, or sodium polystyrene if severely elevated. Monitor glucose closely, as cortisol replacement can initially worsen hypoglycemia before metabolic stability returns. Long-term management aims to replace missing hormones while suppressing androgen overproduction. Oral hydrocortisone at 10 to 20 milligrams per meter squared per day, divided into 3 doses, provides physiologic glucocorticoid replacement. The 3 times daily dosing mimics normal cortisol rhythm better than twice-daily regimens. Fludrocortisone replaces aldosterone in salt-wasting forms. Start at 0.1 to 0.2 milligrams daily, adjusting based on electrolytes and renin levels. Infants also need sodium chloride supplementation, 1 to 2 grams daily divided with feeds, since breast milk and formula contain insufficient sodium for their needs. Stress dosing becomes critical during illness, surgery, or trauma. Triple the hydrocortisone dose during moderate stress like fever or vomiting. For severe stress like surgery, give 50 to 100 milligrams per meter squared IV, then taper over several days. Parents need written emergency plans and injectable hydrocortisone for situations when oral dosing isn't possible. This preparation prevents adrenal crisis during inevitable childhood illness. The ACTH stimulation test differentiates adrenal insufficiency from CAH and confirms normal adrenal function. You'll use this when baseline cortisol levels are borderline or when clinical suspicion remains high despite normal initial values. Start by drawing baseline cortisol and 17-hydroxyprogesterone levels. Then, administer synthetic ACTH, cozintropin, at 15 micrograms per kilogram with a maximum dose of 250 micrograms. This synthetic hormone mimics natural ACTH, but provides a standardized stimulus. Draw repeat cortisol levels at 30 and 60 minutes post-injection. Normal adrenal glands respond robustly. Cortisol should rise to at least 18 to 20 micrograms per deciliter, often higher. This demonstrates intact adrenal tissue capable of responding to stimulation. Values below 18 micrograms per deciliter indicate adrenal insufficiency. The glands cannot produce adequate cortisol even with maximal stimulation. In CAH, the pattern differs completely. Cortisol may rise minimally or not at all, but 17-hydroxyprogesterone skyrockets. Levels exceed 10,000 nanograms per deciliter, sometimes reaching 50,000 or higher. This massive elevation occurs because ACTH stimulation drives more substrate through the blocked pathway, causing extreme accumulation. Timing affects interpretation significantly. During the first 24 to 48 hours of life, maternal cortisol crossing the placenta can create falsely normal results. The newborn's adrenals haven't fully activated yet. If clinical suspicion remains high, repeat testing after 72 hours of life provides more reliable results. Additionally, premature infants may have immature adrenal responses that normalize with time, requiring careful interpretation of borderline results. Certain glucose disorder presentations demand immediate recognition and aggressive intervention. When an infant requires glucose infusion rates exceeding 10 milligrams per kilogram per minute, you're dealing with pathologic hyperinsulinism or a severe metabolic defect. Normal hepatic glucose production maxes out at 6 to 8 milligrams per kilogram per minute. Requirements beyond this indicate excessive glucose consumption. The critical sample transforms your management from empiric to targeted therapy. Draw it during documented hypoglycemia below 40 milligrams per deciliter. This single blood draw captures insulin, cortisol, growth hormone, ketones, and fatty acids when they're most diagnostic. Missing this opportunity means prolonging the diagnostic odyssey and delaying specific treatment. Infants of diabetic mothers who develop multiple complications require heightened vigilance. The combination of cardiac dysfunction from septal hypertrophy, respiratory distress from delayed lung maturation, and severe persistent hypoglycemia creates a perfect storm. These babies often need intensive care support while their hyperinsulinism resolves over days to weeks. Hyperinsulinism that fails to respond to diazoxide represents a therapeutic emergency. These cases may have diffuse nocidioblastosis or focal adenomas, requiring octreotide or even pancreatectomy. Early endocrinology consultation and potential transfer to specialized centers become essential. The connection between persistent hypoglycemia and CAH deserves emphasis. Cortisol deficiency contributes to hypoglycemia through multiple mechanisms: impaired gluconeogenesis, decreased glycogen stores, and enhanced peripheral glucose utilization. Any neonate with unexplained persistent hypoglycemia needs cortisol and 17-hydroxyprogesterone levels checked, especially males who lack the genital findings that prompt earlier CAH evaluation in females. The electrolyte combination of sodium below 130 milliequivalents per liter with potassium above 6 milliequivalents per liter in a newborn equals CAH until proven otherwise. This pattern is pathognomonic. No other neonatal condition creates this specific abnormality. Start treatment immediately based on these values alone. Waiting for 17-hydroxyprogesterone results during acute crisis wastes precious time. These specialized tests often take days to return. By then, untreated infants may develop cardiovascular collapse, seizures, or death. Clinical diagnosis based on electrolytes and presentation justifies immediate hydrocortisone administration. Ambiguous genitalia combined with electrolyte abnormalities confirms CAH diagnosis with near certainty. This combination eliminates other causes of atypical genitalia like androgen insensitivity syndrome or 5-alpha reductase deficiency, which don't affect electrolytes. Begin treatment while completing confirmatory testing. Stress dosing prevents life-threatening decompensation during illness. Parents must understand that their child cannot mount a normal cortisol response to stress. Any fever, vomiting, or significant illness requires tripling the maintenance hydrocortisone dose. Provide written instructions and ensure parents have injectable hydrocortisone for emergencies when oral dosing is impossible. An unexpected complication occasionally emerges after starting treatment: diabetes insipidus. As cortisol replacement corrects the severe illness, previously masked posterior pituitary dysfunction may become apparent. Monitor urine output and sodium levels carefully during initial stabilization. Rising sodium with dilute urine suggests emerging DI requiring DDAVP therapy. This association, while uncommon, appears frequently enough to warrant routine monitoring during CAH crisis management. Clinical decision-making in neonatal endocrine disorders hinges on recognizing key patterns and asking the right questions. First, determine whether hypoglycemia is transient or persistent. Transient hypoglycemia resolves within 48 hours with basic support. Persistent hypoglycemia continues despite adequate feeding and standard glucose infusion. This distinction drives your entire diagnostic approach. Electrolyte patterns provide immediate diagnostic clues. Sodium below 130 milliequivalents per liter combined with potassium above 6 milliequivalents per liter points directly to CAH. No other neonatal condition creates this specific pattern. When you see these values, start hydrocortisone before confirmatory tests return. Physical examination findings narrow your differential instantly. Ambiguous genitalia in a newborn requires systematic evaluation, but when combined with electrolyte abnormalities, CAH becomes your primary diagnosis. This combination eliminates other disorders of sex development that don't affect electrolytes. Glucose infusion rate requirements reveal underlying pathology. When rates exceed 10 milligrams per kilogram per minute, you're beyond normal hepatic glucose production capacity. This indicates hyperinsulinism, fatty acid oxidation defects, or severe enzyme deficiencies, not simple feeding difficulties. Treatment response provides diagnostic information. The infant who stabilizes quickly with standard interventions has transient hypoglycemia. Poor response to appropriate therapy suggests intrinsic metabolic defects requiring specialized testing and management. The ACTH stimulation test timing requires clinical judgment. Perform it when baseline cortisol is borderline, when clinical features suggest adrenal insufficiency despite normal initial labs, or after the first 72 hours of life when maternal hormone effects have cleared. Pattern recognition accelerates diagnosis and treatment in neonatal endocrine emergencies. A female infant presenting with ambiguous genitalia plus electrolyte abnormalities has CAH. This combination is virtually pathognomonic. Start hydrocortisone immediately while confirming with 17-hydroxyprogesterone levels and karyotype. Persistent hypoglycemia requiring high glucose infusion rates indicates hyperinsulinism. These infants need 12, 15, sometimes 20 milligrams per kilogram per minute of glucose, far exceeding normal requirements. The critical sample during hypoglycemia confirms inappropriate insulin secretion. Prepare for diazoxide therapy and potential surgical intervention if medical management fails. The infant of a diabetic mother who develops both hypoglycemia and cardiomyopathy requires comprehensive monitoring beyond glucose checks. Cardiac dysfunction from septal hypertrophy can compromise perfusion and worsen metabolic instability. Monitor cardiac function with echocardiography, track electrolytes for associated abnormalities, and watch for polycythemia requiring intervention. These infants often need several days of intensive support while multiple organ systems recover from chronic intrauterine hyperinsulinemia. The normal-appearing male infant in salt-wasting crisis represents CAH's diagnostic challenge. Without external genital abnormalities to prompt early evaluation, these boys present between 1 and 2 weeks with profound dehydration, shock, and characteristic electrolyte changes. This scenario reinforces why newborn screening includes 17-hydroxyprogesterone. Catching these infants before a crisis develops saves lives. Part 1 covered 3 critical areas of neonatal endocrinology. For glucose disorders, we emphasized the critical sample technique, obtaining diagnostic labs during hypoglycemia below 40 milligrams per deciliter captures insulin, hormones, and metabolites when they're most revealing. We explored the unique challenges of infants of diabetic mothers who face multiple complications from chronic intrauterine hyperinsulinemia affecting multiple organ systems. Congenital adrenal hyperplasia emerged as the most important endocrine emergency in newborns. The pathognomonic electrolyte pattern, low sodium with high potassium, enables immediate diagnosis and treatment. Recognition of this pattern, especially in male infants without obvious physical findings, prevents life-threatening salt-wasting crisis. The ACTH stimulation test provides crucial diagnostic information when properly timed and interpreted. We covered the protocol using 15 micrograms per kilogram of cozentripin, expected cortisol response above 18 to 20 micrograms per deciliter, and the massive 17-hydroxyprogesterone elevations seen in CAH. Remember that testing too early may yield false results from maternal hormone effects. Part 2 will expand our endocrine focus to include thyroid disorders, from congenital hypothyroidism to thyrotoxicosis. We'll explore pituitary dysfunction, including growth hormone deficiency and diabetes insipidus. Mineral metabolism disorders, particularly calcium and phosphorus abnormalities, round out our comprehensive review of neonatal endocrine conditions.